coming weeks. We will also include the slide deck. If you have questions as we walk through the presentation, please go ahead and submit those using the chat feature in WebEx. It may default to sending the message to everyone, so just change it to my name. Okay, so just a few items about the agenda. We are going to follow up with a very brief overview of ICSA Labs for those on the call who may be unfamiliar with us. Next, I'm going to discuss a general overview of items that are relevant to the criteria we're discussing today, and that's going to be followed by a review of the testing requirements for the clinical criteria A1 through 15. And then I will turn it over to Kevin Brown, who's going to walk you through the privacy and security framework, the test requirements for the security criteria D1 through 11, and then we're going to wrap up the day with next steps, including anticipated launch dates and upcoming webinars. So just a little bit about us. We've been in business over 25 years. We were actually the first commercial lab to receive ISO 17025 accreditation for information security testing. We provide expert third-party evaluations of both deployed and proposed technologies. And we focus on testing and evaluation of not just health IT products, but also IT security products, applications, devices, and any solutions against an industry-accepted criteria. We, of course, have significant involvement in the healthcare community with not just the ONC Health IT certification program, but also Concert by HIMSS and the IHE International Conformity Assessment Program. Next, I just want to talk a little bit about our international accreditation. So we have ISO 9001, and that's for our quality management systems. It makes sure that we operate under a credible framework. We also are accredited under 17065 by ANSI as a certification body. We are accredited by NAVLab as an accredited test lab for ISO 17025. And of course, we are authorized by the ONC to do their ONC Health IT certification program testing. Next, just a little criteria overview. So these items are relevant to all of the criteria we're going to be talking about today. First, I want to point out the different certification categories. Those highlighted, A and D, are the ones we're talking about today. There are 60 total criteria, and we'll be focusing on 26 of those. You'll notice as we walk through some of these that there are some criteria that have optional requirements within them, but no criteria are fully designated as optional any longer, and again, we'll talk about some specific examples of those. You're also going to discover that there are no longer any domain-specific criteria. So, for example, in the 2014 edition program, we had like an ambulatory-only criterion for clinical summaries. We had an inpatient-only criterion for electronic medication administration. Instead of that, in the 2015 program, what we're going to see is that there is domain-specific optionality within a criterion itself. So, for example, the demographics criterion has a few data elements that are only applicable to the inpatient domain. And we'll talk about those as we do our entire webinar series, so you know what those options are. And then just taking this a step further, want to make sure everyone is also aware that that means in the 2015 edition program, there is no longer the concept of domain-specific certification. So instead of being, a complete EHR or a modular EHR certified in the ambulatory or inpatient domain, you're now just going to receive a health IT module certification that is domain agnostic. There are 3 types of criteria: unchanged, revised, and new. Unchanged are those criteria that are eligible for GAP certification. So GAP eligibility means that the test lab may not require any functional testing of the criterion when you're going through the certification process. Revised means that they have changed the standard, added new capabilities, or perhaps it's a new capability within an existing criterion that wasn't previously certified. And then, of course, we have brand new criteria. We have 19 of those. And those are criteria that we haven't seen in past certification programs by the ONC. We have 4 new clinical and security criteria that we're going to talk about today. So brand new for the 2015 edition program, A14 implantable device list, A15 social, psychological, and behavioral data. And then for security, we have D9 and D10, and that covers trusted connections and auditing on health information. We have 5 revised clinical criteria: demographics, problems, clinical decision support, family health history, and patient-specific education resources. And we will walk you through what those differences are. There are also 3 revised security criteria for auditable events, audit reports, and integrity. There are 14 unchanged clinical and security criteria. And remember that unchanged means that they're gap eligible. So we have 8 clinical criteria and 6 security criteria that are gap eligible. However, you will notice that 4 of those criteria on this slide are showing up in red font, and there's good reason for that. For A1, 2, and 3, so those are the 3 CPOE criteria, there's an optional reason for order data element that's been introduced. It is optional, so you don't have to test it. But if you do want certified on the optional data element, it would need to be tested, of course. So even though all of the other steps for those criteria may be exempt due to gap eligibility, if you want to show that you can support the reason for order data element, you would need to test that. Also for criterion D6, emergency access, we will be looking at that item differently as well, even though it is gap eligible. The ONC introduced a new requirement that emergency access must be done electronically. So in the 2014 edition program, the ONC had provided guidance that systems have the ability to demonstrate using manual methods like a written password on a hard copy piece of paper. That is expressly not allowed anymore. And so we will be looking at that and maybe doing some spot checking just to make sure that your system is conformant with that. Next up, we want to talk about the clinical criteria and specifically how you're going to be testing those in the 2015 edition program. On this slide, I have put all 3 of the CPOE criteria because they have similar requirements. It's just different based on the type of order that's being written. I do want to draw your attention to the right side of the screen in the upper right-hand corner. We have some information listed there. This talks about dependencies. So criteria A1, 2, and 3, if you want to test any of those criteria, you are also required to test criteria D1 through 7 and G1 through 5. Now, I put G1 through 5, but it's really G1 or 2 and then G3 through 5. And then just a notation here on this slide that it is gap eligible. And like we just talked about, gap eligibility will exist except for the reason for order optional data element. Otherwise, there's really no substantive change in testing to this criterion. We're still going to test that your system can record, change, and access med orders, lab orders, and imaging orders. Next up is A4, drug-to-drug and drug-to-allergy interaction checks for CPOE. I just want to point out that everything on the left side of the screen for the 2014 edition program, that is still applicable. So all 3 bullets there, still the same functionality that we're going to see in the 2015 program, but the ONC did provide some additional clarification. So they have constrained it to say that interaction checks are confined to CPOE functionality, and interaction checks are not required in any other cases. So your system doesn't have to perform drug-to-drug or drug-to-allergy interaction when, perhaps medications are being reviewed or a med list or medology list is being updated. So it's really restricted to CPOE. They also clarified that the checks are based on structured data within the system. So otherwise, no huge changes here, just still testing the system's ability to trigger those drug-to-drug and drug-to-allergy interactions, as well as being able to adjust the severity level. Okay, A5, lots of changes here. So Everything on the left-hand side has been replaced with what you're going to see on the right-hand side of the screen. So, new preferred language standard was adopted because it is compatible with CCDA Release 2.0. And it can also have the languages that are in ISO 639-1, -2, and -3 can be mapped to it. So you will need to use RFC 5646. For sex, you now need to record that using HL7 version 3. And this is intended to record the patient's birth sex, okay? It's not about their gender identity or the reassigned sex of the patient. This is simply recording the patient's birth sex, and the options available under that standard are male, female, or unknown. For race and ethnicity, you must be able to record the race and ethnicity that is in the CDC code system in the FIN-VAD system. There are over 900 options available. However, the ONC has said that HIT developers and providers can determine the best user interface implementation, but for certification testing purposes, you do have to be able to support all of those. You will also see that it needs to be aggregated to the OMB standard for race and ethnicity. So really 2 standards there for race and ethnicity. In the 2014 program, the system only had to record when a patient declined to specify race, ethnicity, or preferred language, and they have added on to that. So now the system needs to record when a patient declines to specify race, ethnicity, both race or ethnicity, preferred language, sexual orientation, or gender identity. Now, the CCG, that's the Certification Companion Guide, does state that the system must be able to decline to specify both race and ethnicity, and I'm sure some of you are wondering what in the world that means. And so we believe both is referring to those systems who are using the combined format with the OMB standard. So that standard permits merging of the ethnicity and race categories. So if you do that, they're simply trying to let you know that you still, if you're using that combined format, your system still needs to be able to support some sort of patient declination option. We have asked the ONC for clarification on that, but that is our current interpretation. I do, however, want to point out for those who may be considering using the combined format that other criteria you may be testing to, like any criteria that require you to create a CCDA or maybe QRDA files for clinical quality measure testing, they do require race and ethnicity to be exchanged as separate fields, so that's certainly something you'll want to take into consideration. For the date of death, this has been added for the inpatient domain. So this is a great example where we see some inpatient or domain-specific functionality embedded within the criterion itself, and the test labs will be able to maintain and record that discreetly, and that will be pushed to the chapel site so that people know that you did that extra option and you were able to record the date of death for the inpatient domain. They also added the sexual orientation and gender identity data elements, and those two require HL7 version 3 and SNOMED for recording. So lots of changes for this particular criterion. Next up is problem list. So not a lot of changes here, and a lot of you might wonder why it's not gap eligible. And we believe it's because they have now required SNOMED CT, the September 2015 release, or newer. So if a newer release comes out, you're certainly able to use it, that would be the minimum standard that's required. And so to sort of align with that, since it's not gap eligible, they have stated that attestation is available instead of testing if you're certified to the problem list criterion in the 2014 edition program. So we do anticipate attestation would involve the vendor providing documentation, sort of proving that your system is using at a minimum that September 2015 release of SNOMED, and then that would be evaluated by the test lab to determine compliance. And we anticipate that if approved, no functional testing of criterion A6 would need to be done on test days. So but that's something that you would want to talk to the test lab about, and that's how we plan on handling it though. So the next two criteria, medication list and med allergy list, there aren't a lot of changes here. So again, everything you see on the left-hand side is still applicable. You still have to, for ambulatory, show that you can have a continuous medication list over multiple encounters, and for an inpatient system that it's over the duration of an entire hospitalization. However, we do have a couple clarifications. They have said that med history is intended to include a record of prior modifications to the patient's meds, which I think we probably most of us assumed, but they put that in black and white now. They also said medications aren't defined. And so what that means is if your system supports over-the-counter medications or herbal supplements, those could certainly be included. You could use those to test this particular criterion. It's not required though, right? So it's not a requirement. They're just saying it's permissible if you want to use it. What's very interesting for this particular criterion is that even though the final rule still requires your system to be able to access a medication history list, we don't see that in the final test procedure. The draft test procedure had it, but it's not in the final TP, so we have requested clarification from the ONC on that. Very similar to what I just talked about for medication list, everything I just said just continues to apply. So medication allergy list, you will notice the changes in testing. This is a gap-eligible item. But again, that accessing the medication allergy history list isn't listed in the test procedure anymore, even though the final rule requires it. So we have requested some clarification on that. Criterion A9, this is another really big one with a lot of substantive changes. So clinical decision support. The info button standard is now required. If you tested this criterion in the 2014 edition program, you will remember that you could have the option of using the info button standard, or you could just use some sort of general capability within the system. That latter is no longer allowed. You do have to use info button standard. They've also removed the terms automatically and trigger, and they've done that just to clarify the intent of this criterion is to encompass all types of CDS interventions. So the ONC doesn't want to be prescriptive about how you choose to deploy the interventions in your system. They've clarified that a CDS is not simply an alert, notification, or explicit care suggestion. It should be more broadly interpreted as the user-facing representation of evidence-based clinical guidance based on relevant patient data. So what you're looking for here is just to think outside of the box, think about how your system can best support your clinicians when they're making clinical decisions about their patients. For the next item on incorporation, so when you incorporate meds, med allergies, and problems from a transition of care or referral summary, you have to use the required standards. And what they mean by that is the required standards found in the 2015 edition demographics and clinical information reconciliation and incorporation certification criteria test procedures. So if you look at the demographics and series test procedures, you'll be able to find those standards. And they've also clarified that the CDS interventions that are based on that incorporated data do not have to trigger at the time of incorporation. It's just that the interventions have to be based on the incorporated data. Automatic display of source attributes isn't required, so that means it's okay if the user has to drill down or link out to view the source attributes. Another thing to note here for the source attributes is that the system doesn't have to create the content for them. So again, you can link out to an external site that has those source attributes located on it. So I think that's a really helpful clarification. If there's no bibliographic citation available, the system now has to indicate that. So it can't just be blank. You have to have the ability to indicate that there is no biblio citation. They've clarified and provided the definition of what a developer is, and I provided that here for you. It's basically a knowledge vendor. They've also talked about the definition of a funding source and have talked about it being the work performed by that developer. And again, here we see, just like with the biblio citation, that if it's unknown, the system has to still be able to indicate that. The final change is regarding the diagnostic and therapeutic references. So in the 2014 program, if you look on the left-hand side of the slide at the very last bullet, that was based on problems, meds, and labs, plus a combination of 2 or more of those data categories. They have now dropped labs and has replaced, and it's been replaced with the demographics data element. So you now have to create diagnostic and therapeutic references on problems, meds, and demographics, and then we also still continue to see that combo requirement. One thing I will say is to just remember that the demographics data elements now include sexual orientation and gender identity. And that means that you now have those data elements available for providing and creating CDS interactions. You aren't required to use them, of course, but they are an additional data element up for grabs when you're demonstrating the diagnostic and therapeutic references based on the demographics data element. Okay, A10, drug formulary and preferred drug checklist, or sorry, preferred drug list checks. This is GAP eligible. Not a lot of changes here, just a couple of clarifications. The first one is that there isn't a required standard, but they have recommended that you could use the NCPDP formulary and benefit standard. It's widely supported widely used to support the Medicare Part D requirements. And just a note, if you are using those, you would need to download those drug formulary files and incorporate them into your system. They've also clarified that it's not permissible to use a hyperlink to a patient's drug formulary, that a user must manually open and investigate. So remember, it needs to be this automatic function, and so it shouldn't require the user to, manually walk through a drug formulary list to figure out whether or not what's being prescribed is required and is on that list. I also just want to point out that this last bullet here under the 2014 edition section, and again, everything under the 2014 edition side is still applicable in 2015. Just want to point out that that last bullet on the left there is specific to a drug formulary, right? It's not a documentation or requirement for a preferred drug list, so it's just for drug formulary. Smoking status. So not a lot of substantive changes here. The biggest change is that SNOMED is no longer required. You can certainly use it if you'd like to, and I put a note there that there are other criteria. So any criteria that use the CCDS, and that's the Common Clinical Data Set, they do require SNOMED codes when you're exchanging smoking status. So that may be a reason if you're testing some of those other criteria that require it, why you'd want to demonstrate it here. But officially, SNOMED isn't required. And they've also provided some clarification that it's limited to any form of tobacco that is smoked. But that's just for certification testing, right? So you can still, your system can still capture other forms of tobacco use that are not smoked. Okay, family health history. SNOMED now is the only required for diagnosis. You'll notice that they dropped the HL7 pedigree standard. They have also said that it is up to the developer how the system will represent the familial relationship, but they did provide some examples for you. Again, you aren't bound to these examples. You can do whatever you want. But for familial relationship, it can be represented using the pre-coordinated SNOMED CT codes that link both a relationship with a diagnosis, or you could choose another method for coding that relationship, and the way you could do that would also be using the HL7 pedigree standard, even though it's not required. They also clarified that unstructured or free text of family health history isn't permitted, and I think we really honestly saw that in the 2014 program as well. A13, patient-specific education resources. Not a lot of changes here. Two things that are notable is that they have dropped the one other EHR function, and now you're only allowed to use info button. They have also dropped the requirement that you find resources based on problems, meds, and labs. Instead, it is now just problems and medication. So they've dropped lab tests. They also provided some optional data elements. So you can also provide or locate patient-specific educational resources using preferred language. Again, it's optional, not required. Okay, the next two criteria are brand new. This is the implantable device list. One thing I want to point out in the green icon in the upper right-hand corner, if you look at the certification companion guide for A14, it states that it doesn't state that it's required for usability testing. However, I included G3, which is the usability safety enhanced design criteria, on this slide because I believe it is required. The final rule, as well as the G3 test procedure and certification companion guide, are all aligned and state that it's required. So I think it's just a typo on the CCG for A14. So we have asked the ONC to update that. This slide, it looks a little differently than the others. On the left, we have information about how it's tested, and on the right, we have information about the clarifications. So first, the unique device identifier, or UDI, just want to talk about what that looks like. So it has two parts for those who aren't familiar with it. You have the device identifier, which identifies the labeler and the specific version or model of the device. And then there's also the production identifier. So the production identifier includes the lot or the batch number. It would include things like the serial number, expiration date, the manufacturer date, as well as a distinct identification code for a human cell, tissue, or cellular and tissue-based product. So production identifier has a lot of info in it. So for testing purposes, the system needs to be able to record and change the UDI and the status. System also has to be able to record the UDI in all formats established by the 3 UDI issuing agencies. Your system also has to be able to parse out those individual device identifier and production identifiers from the UDI and store those as easily readable plain text. And there's a clarification on that I'll get to in a moment. The system also has to obtain and associate with each UDI the description of the implantable device. And then there are some requirements for how you do that, and I provided the example underneath that bullet. Next, there are 5 GUDed attributes that have to be associated with the device, and GUDed stands for Global Unique Device Identification Database. So there are 5 attributes there that have to be associated. The system also needs to be able to create a list, and that list needs to contain the unique device identifier, the description, and the method with how to access those unique device identifiers. And then finally, the user has to be able to access the UDI, the device description, the UDI identifiers, and the UDI attributes. So there's a lot going on in this particular criterion. As far as clarifications go, they are agnostic on how the UDI is captured, but it is not intended that a user would manually enter it, right? So it's not expressly forbidden by the test procedure, but it's certainly not best practice that you would have a user manually enter that. And the reason for that is that these UDIs are captured in a variety of upstream IT systems. So in the real world, it would be really unlikely that the user in your system would be manually entering it. And there's also an expectation, again, not a requirement for certification testing, but there's an expectation that you would develop functionality to indicate the reason whenever a UDI status was changed. So you might have a field in your system that talks about, the reason the UDI status was changed that a user could fill in when they were changing the status. Now, for certification testing, this is how we differ a little bit like in the real world, right? So in the real world, the UDI is probably already going to be parsed. And if that happens in real life, your system would not have to re-parse the info, right? It would just need to obtain it and store it. But for certification testing, we actually will be checking to see that your system has the ability to parse the data. For that list that the system has to create that we talked about, it does not need to include inactive UDIs, but if it doesn't include it, there has to be some other method to the user letting them know how they could access those inactive UDIs. So that data still needs to be available to them. And then finally, this goes back to the easily readable plain text item. So they have said that if you provide the user access to each discrete component, so all of the device identifier attributes and the production identifier attributes, that would be equivalent to providing them access to the full UDI in easily readable plain text form. Okay. Last clinical criterion, social, psychological, and behavioral data. For this one, there are 8 different domains that you have to test and certify. So we've listed those there roughly or quickly. It's financial resource strain data, education, stress, depression, physical activity, alcohol use, social connection and isolation, and exposure to intimate partner violence. Those are the 8 domains. You are required to record change in access data for all 8 domains. So you could not come and be certified on 7 domains or 1 domain or 3 domains. Your system has to be able to support all 8 domains. You also have to make sure your system can support that decline to specify option for all 8 of those. And it does require both LOINC and the Unified Code of Units for measure. We also have just a couple of clarifications from the ONC. Again, the first one is not part of certification testing, and this would be more for providers who are using your product for this particular criterion. They're just recommending that those institutions develop policies for the collection and the dissemination of the data. Finally, what's really important here is if you look at the test procedure for A15, it's going to be pretty bare bones. So I would recommend that you look at the CCG, the Certification Companion Guide. It has all of those LOINC question text and associated codes at the end of that document. And so I think that'll be really helpful in understanding what information you need to collect, how it should be collected, what it might look like. So definitely recommend you use that as a resource. Next, I would like to turn it over to my colleague, Kevin Brown, and he is going to walk you through the remainder of the presentation. So Kevin, whenever you're ready.
Thank you, Michelle. Go ahead to the next slide. So this is a list of the 2015 privacy and security criteria. You'll notice the 2 new ones here, D9 and D10. The other 9 were pre-existing, although several of them have changed. Next slide. So the significant change to the security and privacy criteria has to do with how it applies to the rest of the criteria. So no longer will you necessarily just automatically test authentication or audit log, regardless of what other criteria you test. When you select certain, say, clinical criteria to test, there will be specific security criteria that you have to test along with it. So the security criteria that you're required to test will be determined by the other criteria that you've selected. And then to demonstrate compliance, there will be 2 ways known as Approach 1 and Approach 2. Approach 1 is the technical demonstration, which is more like what you folks are probably accustomed to. We will actually demonstrate the functionality, and we anticipate that the vast majority of testing will be done that way. Approach 2 is through system documentation. We're still finalizing the exact details on how that will occur, but think of it as something like, let's say you're testing to the authentication criteria D1, and you integrate with Microsoft Windows Active Directory domain. You would submit documentation on how your product integrates with Active Directory instead of necessarily being required to demonstrate it. The amount of documentation required is probably going to vary depending on exactly what you're integrating and the familiarity with that system. So again, we're anticipating the majority of people will be using technical demonstration, but you do have the system documentation approach available to you as well. And the goal of of this is to ensure that each product submitted for testing possesses the relevant privacy and security capabilities. So an example of that would be, let's say that you have a login interface to your EHR, but you have a third-party e-prescribing interface that you log into via a website. It'll no longer be sufficient to just demonstrate login one time and automatically assume that that applies to all of the features you're demonstrating for certification. You would have to demonstrate authentication to the EHR interface, and then separately you would have to demonstrate authentication to the e-prescribing interface as well. But if that functionality is all performed behind one login interface, if your e-prescribing is built into your primary EHR interface, then you would only need to demonstrate it once. But for each aspect that you're going to be demonstrating for certification, if there is a separate login interface, you would need to demonstrate that separately. And then that would apply to the other applicable security criteria as well. Next slide. Now, there are some criteria that are exempt from the privacy and security framework. So within the privacy and security criteria themselves, there's no interdependency. So nothing that says that if you test authentication, you must also test audit log or anything like that. Also, G1 through G6 do not have any dependent security criteria. ONC has determined that those criteria don't have any kind of impact on security as it relates to electronic health information. When you do select Approach 2, the goal is that when different HIT modules share a common security infrastructure, that the developer would only need to certify that infrastructure once. Like I said, something like Active Directory. The Approach 2 does not allow you to attest that for some reason privacy and security criteria are inapplicable to your product or they're somehow infeasible. It's not optional. You can't attest out of them. You must demonstrate them as required. Now, one of the things I mentioned previously is if all the functionality is provided via one interface or one function, then you would not have to test them independently. You'd only have to test it once. The exception to that is E1 and E2, which is if you download, transmit, and secure messaging. They will both always be tested independently to D9, which is trusted connection. So you will always need to verify that you have an encrypted and integrity protected link or an encrypted document or message for E1 and E2, and they'll be tested separately each time. Now, how these are actually implemented in the real world, that's essentially going to be outside the scope of certification, but that'll be guided pretty much by the federal and state privacy and security laws. And that's a direct quote there from the final rule. Next slide. Now, here's the actual table that shows the framework. So, Michelle spoke about the clinical criteria earlier today. That's the 315A. So you would need to do D1 through D7. And as you go down the list for the different criteria, you'll see how they're grouped. Generally, they're grouped by category A, B, C, F, and H. But the E criteria and the G criteria, they've broken out individually. So G, 7, 8, and 9, that's the API criteria. You would need to do authentication, and you would need to do trusted connection, and then either D2 or D10. And I'll talk about the differences between those in a little bit. Likewise, for E1, E2, and E3, there's some slight differences there. But this is a table you guys will probably want to refer back to as you prepare for your certification, so you understand exactly which security criteria you'll be expected to demonstrate. Next slide, please. So now let's talk about the actual criteria and the changes from 2014 to 2015. Next slide. So for these 5 criteria, authentication, amendments, automatic access timeout, end-user device encryption, and accounting of disclosures, there were no substantive changes. That means they're gap eligible. Now, if for some reason you would have if you have a different login interface, you may have to test that separately. So you might be gapped for some criteria, and you might not be gap eligible for other criteria. Same thing with automatic access timeout or end-user device encryption. But generally speaking, these are gap eligible. Next slide, please. So for D2, the auditable events and tamper resistance, under 2014, there was a list of events that you needed to capture. Anytime electronic health information was added, deleted, modified, and so on. Also for things like disabling the audit log or disabling end-user device encryption. For 2014, they did not require any changes to user privileges or emergency access events. In 2015, those are required in addition to all of the pre-existing requirements. So those were the two noticeable changes there. Otherwise, the criteria remains pretty much the same. Next slide. So for D3, similar. You did not have to display any log events related to changes in user privileges or emergency access events. And NTP was not required if you were testing just D3, although it was required for D2, and most people tested both. For 2015, again, it'll include all the same existing requirements. They are, of course, adding the 2 additional events from D2 for the changes to user privileges and emergency access events. And they have added NTP as a requirement. Next slide. For emergency access, so Michelle spoke about this one earlier. It is technically gap eligible. However, in the past, the way some developers met this requirement was through a manual means, whether it was writing credentials down on a sheet of paper and locking them in a desk drawer or a vault, or having to make a manual request to another, say, IT administrator who would then change the permissions and at the end of the emergency access event change them back. What they're saying is now this must all be demonstrated electronically. So if you demonstrated it electronically for 2014, it would be gap eligible. If not, you would have to re-demonstrate the entire criterion. But we actually anticipate that a lot of developers will need to demonstrate this one again. Next slide, please. So integrity was initially SHA-1 was the minimum standard required. SHA-1 is being deprecated by a lot of different standards and a lot of different uses. And in the case of the 2014 criteria, it was permitted then. It will not be permitted for 2015. They're now going with a SHA-2 minimum standard, which could be SHA-256, SHA-384. Those are all subsets of the SHA-2 standard. In 2014, there was no specific use case stated. So we would get a lot of questions prior to testing. Well, how do we demonstrate this? What is this for? What is the purpose? This is a significant change for the integrity criterion. This is required if you're testing any of the B criteria. In the final rule, they actually state that they expect but do not require that this would be paired with B1 most often. Now, B1 being the exchanging of transitions of care, both sending and receiving. That's where they would expect this to be implemented. But it could also apply to e-prescribing or any of the other B criteria as well. Next slide, please. D9 trusted connection. This is a new one. There are 2 primary ways to demonstrate this one. The first method is a message level encryption, and that is where you would send an encrypted like email message or attachment or some sort of the document itself is encrypted. It may not be email, and then sent over an unencrypted connection to another user. The other method would be the transport level, and that would, of course, be sending over an encrypted connection. So maybe an SSL connection, a direct messaging connection, or even possibly something like IPsec. When testing D9, if you're testing E1 and E2 both, you need to test D9 separately. This criterion is also applicable to E3 and then G7 through 9, which are the API criteria. So for E3, G7 through 9, you may be able to test it only once, but for E1 and E2, you'll need to test it individually. Now, for transport level connections, SSL is not explicitly required. ONC is anticipating that would probably be the most common method of meeting this requirement, but it is not explicitly required. If you're doing the message level encryption, and this is an important note to make, the file being encrypted and the hashing would need to be done independently. So you would need to take a hash of the file, encrypt it. Let's say you're sending as an encrypted attachment via email. When the recipient receives it, they would then need to decrypt it and then perform their own hash and verify that the hash has not changed. And as I mentioned before, in a transport level, the link itself would be encrypted and integrity protected. So that would be combined together. All right, next slide, please. Now, this one is basically an abridged version of D2. They have provided this one specifically related to G7 through 9, the API criteria. What they basically stated is that if you're only doing the API criteria, some of the other required features for D2 may not be applicable. So they've removed some of those other features that they've deemed not relevant, and so you would only be testing a subset of those requirements. There's just fewer required log events. And the example would be no requirement to log events for when the audit log is enabled or disabled, or the encryption status is enabled or disabled, and so on. Next slide, please. So next steps, that covers all the security criteria. Go to the next slide, please. Just so you guys are aware, these folks are aware, we have anticipated that we'll have a prep packet and our study guide available sometime around March 1st, and that'll be available for purchase at that time. And we will be launching the program no later than March 31st. That's the current timeline. We seem to be on track for that. And next slide, please.
Again, I just wanted to add some information about the prep packet.
Sure.
If you are interested in that, please email me after this session, and I can put you on the list of individuals who will reach out to you as soon as it is available. And you will find my contact information on the last slide. So thanks, Kevin. Go ahead.
And we will be making that available for a fee in advance of testing, correct?
Correct, yep, and I can give everyone the details if they reach out to me.
Okay. So in addition, we do have some additional upcoming webinars. You've probably received emails about each one of these to address different criteria, kind of like we've done here today. If you've not registered for them, you can go to that link at the bottom of the page there and register for our additional seminars. And we'll be covering, for example, on the 25th of this month, we'll be covering the B, C, and E criteria. On the 17th of March, this will be presented by our certification body to discover certification, disclosure, and transparency requirements. And then the other criteria will be spread out over March 10th and March 24th. And then here's a couple additional links. This will probably get you started if you haven't seen some of these before. The final rule, the approved test procedures, along with the certification companion guides. Just so you're aware, if you're not already, the certification companion guides are separate from the test procedures, but they do provide a lot of additional useful information to help with the interpretations and understanding of the test procedures. They also will provide a lot of links to associated standards and whatnot. And of course, the 2015 edition test tools, if you want to begin testing against some of the test tools, you can access them from that link there. Next slide, please. And there's our contact information if you have questions about any of the criteria that we've covered today. Feel free, if you haven't submitted your questions to Michelle via the chat feature yet, please do so now, and we'll try to answer as many questions as we can here in the remaining 10 minutes.
Great, thanks, Kevin. And we do have a few questions that have come through. So a couple of questions were about whether we were going to provide the slide deck and the recording, and the answer to both is yes. Those should be on our website by late next week. We will have the recording available as well as the slide deck available for everyone. We also had a question about, I believe this is criterion A5 demographics. The question from Jessica was, if you aren't using that combined OMB format for race and ethnicity, do you need to support the combined decline to specify for race and ethnicity? And that's a great question, and so the answer is no. So if you aren't using the combined format, perfectly fine for you to have a decline to specify option for race and then a separate field for ethnicity. The next question was about criterion A14. Are there exclusions for UDI, so for the unique device identifier recording, for certain healthcare niches such as dental? And Elliot, I do not believe so, but if you want to follow up with me via email, we can discuss further about what you're thinking regarding that, and we can make sure we get some good advice for you. The next question is on criterion A12, and the question is whether that particular criterion is GAP eligible. So this is the family health history criterion, and the answer, Sean, is no, it is not GAP eligible. They made a number of changes to that. The most substantive one, no longer allowing the use of the HL7 pedigree standard. So you would need to use the SNOMED standard and do the testing for that. Okay, Kevin, this one is for you. This is regarding the trusted connection criterion. So how do you intend to prove/test a trusted connection? So how would a system prove that the API is available via HTTPS?
That's actually a very good question as well. We've reached out to ONC for additional clarification on how they want the API criteria tested specifically. That is something that they're going to be offering additional training on in the coming weeks. In general, though, for D9, what we'll be looking for is if it's tested through a web browser, we'll be checking the web browser connection and verifying that the certificates were exchanged cleanly and that SSL is in fact being used. Something like IPsec, we would be looking at some sort of log mechanism to verify that connection was set up and using the necessary encryption algorithms and whatnot. For the API, it's probably going to vary depending on how some of the features are implemented by the actual HIT module. So once we get clarification from ONC, we'll have more information available to provide. So if individuals who might have specific questions about that want to send them to me offline, and then when we get the additional information, we can put together an email and send that out to them.
Great, thanks, Kevin. And then there's a question from Carrie asking if there's a minimum amount of standards you need to certify to have a base EHR, and if so, is this listed somewhere? And yes, you would find that information in the base EHR definition, and then you'd have to backsolve from there. So the base EHR definition is table 7 in the final rule, and if you want to send me an email, I can send you a little excerpt of that. It lists all of the criteria that make up the base EHR definition, and from there you can backsolve and look up those particular criteria to determine which standards would be required. The next question is about the test procedures for clinical quality measures. So Laura, that's a great question. So some people found that the 4 clinical quality measure test procedures are not available on ONC's website. You will also find that F as in Frank 5, that test procedure is also not available. We do not know when they will be available. We will be launching the program without them. There are some test tool and standard changes that the ONC is waiting for those to be finalized before they publish those test procedures. So they are not there. We will be doing a future webinar on those once we have the final test procedures so we can educate everyone on those. But for now, we will be launching the program without those 5 criteria. Okay, and let me check through. So a question is, again, someone asked whether they can get the recorded sessions. I'm just going to repeat what I said earlier. Yes, we are recording the session, and we will make that available to you offline. It will be posted on our website by the end of next week. So Beth asked a great question. Will you be supplying test data for any criteria that currently does not have any ONC supplied test data, or are we expected to supply our own? It's a great question. I'm glad you noticed that. So in the 2015 edition program, many of the criteria, if they don't have a corresponding test tool that's required, do not have any test data. To answer your question, yes, ICSA Labs will be providing sample data for you to use. You aren't required to use it. You can certainly create your own if you'd like. But if the test data we create for you works, I'd say go ahead and use it. It would just make everything go a little faster. So we also have a question here about the SNOMED CT. If you choose to use the SNOMED CT for the family health history for the 2014 edition program, would it be okay to keep that this time around? So yes, SNOMED is the required for diagnosis, so you can continue to use SNOMED. Just remember, for the familial relationship, you have to have some way of presenting that as well. And so if in the 2014 edition program you use those pre-coordinated SNOMED CT codes that link both the relationship with the diagnosis, absolutely you could continue to use that. Let's see, we have time for a couple more questions. So with criterion A12, we support structured data. This is from Sharon. Yet we allow the user to input free text, and the question is that allowed? So Sharon, for the purpose of certification testing, unstructured or free text is not permitted. It's okay if your system has that additional functionality, but it certainly wouldn't be the functionality that would be tested for the family health history criterion, because that would require structured data. So during your certification test, that is what you would be demonstrating. And it looks like that's about all we have time for. So what I will do is I will follow up. There are a couple of questions in the chat that are fairly complicated, and just know that I have made a note of those, and I will be following up with you via email so that we can discuss those further. So thank everyone. Thank you so much for your time today. We appreciate you attending our webinar series, and we look forward to seeing you again on the 25th when we talk about the next batch of criteria and those test requirements. Thank you so much. Have a great day.